Good evening, everyone. A warm welcome to all of you today for the National Nutrition Symposium. And we have gathered here for true academics, and it's an absolute pleasure for me to introduce Professor Dr. Anuj Maheshwari, who is the governor of ACP. And under his able leadership, we have seen that ACP has seen greater heights. And what we have seen is that, there is an increase in the number of academic programs, and he has dedicated months. For example, he has been dedicating months towards development of women health, towards nutrition, and he has designated each month for a particular direction, and which is very, very unique. We have seen an ample number of awards being given out from the ACP, and we're looking forward to his able leadership to see ACP being directed in a completely new direction, which was unseen before. He is, of course, a very well-known speaker, and we know that he has spoken at national and international forums. And besides being the governor for the ACP India Chapter, he is also the vice president of RSSDI. And he is also a fellow of various colleges like American College of Endocrinology, Royal College of Physicians, RSSDI, etc. And he has got many, many publications. And it's an absolute honor and privilege to welcome him on board. And sir is going to now, would now request all the faculties, before he introduces the chairpersons, would now request all the faculties, Professor Kamalakant Tripathi, Professor Jayant K. Panda, Professor L. Srinivas Murthy, and also Professor Anuj Maheshwari to please do the inaugural ceremony.
आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you so much. And now I would request Professor Anuj Maheshwari to officially inaugurate this session and also introduce the chairpersons for this evening. Sir.
Thank you, Dr. Supratik, for organizing this wonderful event under the aegis of ACP India Chapter. Although we all know that last month, which was the month of the September, as well as this month of October, has been dedicated to the nutrition, and probably this was the program which have been done in the same series of the nutritional symposia which we have organized. A similar kind of the nutritional symposia we have organized with World Congress of the Nutrition, which we have been witnessed in Haridwar this month, around mid of the month. It was around from 12th to 12th, 13th and 14th of October. So with these words, I shall be starting this program of the day, that is National Nutrition Symposium 2021. Our learned chairpersons are Dr. Jayant K. Panda and Dr. Srinivas Murthy. Both are the learned professor. Professor Jayant Panda is a specialist in the diabetes and critical care. He is in Cuttack SCB Medical College. He is professor in SCB Medical College in the postgraduate department of medicine. He is having the research interest in the field of diabetology and endocrinology. He has also served as editor of journals like Orissa Physician Journal, Orissa Medical Journal, over 40 papers and articles authored by Dr. Panda on subjects relating to internal medicine and diabetes, which have been published in national as well as international journals. So now Professor L. Srinivas Murthy, he is a professor in presently working in which college, I can't see it here.
Ambedkar Medical College.
Yeah,
Ambedkar, Bangalore.
Yes,
Bangalore.
Ambedkar Medical College, Bangalore. He has got the over 19 years experience in both undergraduate and postgraduate teaching. He is also owner of the Life Care Hospital and Research Center at Shankaragada and Bangalore. In Bangalore, he is a former consultant at Fortis Hospital, Glen Eagles Hospital, Global and Apollo Hospital. He has been faced a successful USFDA audit in the field of research and faced world's first ever Canadian audit successfully. He is the principal investigator in over 75 clinical trials and part of landmark trials like HOPE-3, Clarify, Begin, Duel, Elixa, and many, many more. Fellow of the Royal College of the Physician, Edinburgh, and Fellow of Indian College of Physicians, has national and international publications, deliberation in his credit. He has been recently elected as a Fellow of American College of Physicians also, which he has not mentioned here. He has national and international publications, deliberations to his credit. He is faculty at various national and international forums, conferences, and having multiple societies, life member, as well as executive committee member of the RSSTI national body. So with these words, I will hand over the session to both learned chairpersons to take it forward. Over to Dr.
Thank you, Professor Maheshwari. And as governor and as a learned speaker of the day, it's a matter of privilege to chair this session. And this National Nutrition Symposium has created a wave of knowledge on nutrition across the country. And today we have three stalwarts as speakers. And this is the Suresh Chakravarti Memorial Foundation hosted program. And we have Professor K.K. Tripathi, Professor Anuj Maheshwari, our governor himself, and Professor Narsingh Verma. And the topics are the nutrition in pre-diabetic diabetic kidney disease, diabetes and altered immune function, can nutrition help, and nutrition in critically ill patients. To start with, we'll have nutrition in pre-diabetic diabetic kidney disease by Professor K.K. Tripathi. And Professor Kamalaka Tripathi is a known face in the metabolic medicine and nephrology across the country. He is a MD, DM, DNB, and MNAMS FRCP. He's former professor and head Department of Medicine, Institute of Medical Science at BHU Varanasi. He is the former president of Indian Society of Hypertension, Indian Society of Nephrology, in North India Chapter, the Indian Society of Wound Healing, and Uttar Pradesh Diabetes Association, the UPDA, and the founder chairman of RSSDI UP chapter and vice dean of Indian College of Physicians. More than 300 publications to his credit, and 3 international and 25 national awards to his credit. He is the member advisory board of many organizations including CCRAS, Ayush, DGCI, CDSCO, Ministry of Health, Government of India, expert committee member of ICMR, DBT, DST, UGC, and National Board of Examination, invited lecturers deliver in international 26 and national more than 400, and recipient of Guinness Book of World Record for enrolling maximum number of diabetes patients on single day. So Professor Tripathi himself is an institution, and from Banaras, he has created a generation of students, I'll tell, and he is a teacher of teachers. So we are very fortunate to listen today's topic from him, nutrition in pre-diabetic diabetic kidney disease. We present you Professor K.K. Tripathi.
Thank you. Extremely thankful to Supratik, Dr. Maheshwari, and all my colleagues who are there. Is my slide is visible now?
No, sir.
Not
No,
yet
sir.
visible?
No, slides are not visible yet.
Going to
Please
share my
your
slide.
slides.
Yeah. Can you see now? Can you see now?
Yeah,
Yes.
yes, sir. Yes, it has come. Make it full screen, sir.
All right. So thanks for such nice words, and I'm really indebted. Dr. Maheshwari is a brilliant. I was looking at his achievement in this ACPI, his governorship, and one of that has one of the excellent person award. I know, which really looking at his personality, looking at his credentials, looking at his contributions, his academic interest, and keeping everything very high flag in the country and international figure. So thanks you for giving this opportunity. I'm right now at the airport waiting for my for boarding, and really thankful because I learned many things and I prepared this material about 15 days before when I got the topic by Supratik. But then 2 days back, I received another set of slides. So I kept mine and few that as well. Why this is important? Because most of us, the diabetologist, the internist, physician, by the time we receive patient of diabetes, they have some component of chronic kidney disease. And this leads to the limitation in the management before they go for dialysis or a transplant to nephrologist. And nephrologists also need our similar suggestions. This we receive mainly we internist and physician and diabetologist is stage 2 of chronic kidney disease. And by the time we receive them, there are problems. We can manage the blood pressure, we can control the diabetes, we can control the weight. But in the stage 3 onward, these patients, when they have uremic symptoms, they lose their appetite, they keep on vomiting, they have a problem of anemia, which further reduces, and they are hypoxic, and then they get cardiac dilatation, and there's reduced ejection fraction, and they have a malnutrition. This is the time when we have to take care of their nutrition, because ultimately they may go for kidney renal replacement therapy, managing fluid overload, diabetes, everything. So what I would be talking on the different conditions which affects their nutritional status, the comorbid condition, the cardiopulmonary function, various inflammation which they might be carrying on because of the some sickness or because of the infection, lung infection, and they are quite frail people. The residual renal function, they must be on some drugs like angiotensin converting enzyme inhibitors, diuretics, they produce further hyponatremia, therefore appetite could be bad, exposure to many nephrotoxic agent could be there. They are likely to be taken for the hemodialysis. There could be creation of fistula in between, and also relation to the factors which are related to the patient like mood, the adherence, restriction, tolerance, prescription, blood glucose monitoring, and dialysis related problem, which they would come later on. How to monitor these and what are the clinical clue? I made this slide little more clinical oriented. We have to look at the anthropometry and the body composition, their weight, height, BMI, arm circumference, the skin fold, muscle circumference, and muscle area, which certainly would tell us what is present nutritional status in the bioimpedance analysis. We have to evaluate clinically also, like looking at the creatine value, creatine clearance, urea, potassium, sodium, and they're important. I'll talk later. Phosphorus, bicarbonate, transferrin, cholesterol, glycemic condition, protein catabolic rate, urinary protein, and also various dietary event which would modify their intake. How do we assess? We take history and physical examination, weight and muscle mass. We look at the history, the food, and there is subjective global assessment phenomena by which we use either recall phenomena, anthropometry, and biochemical laboratory. This is a little costly. You can look at the nitrogen excretion in the urine, and that can you can predict how much protein they are losing, and look at the liver function test, serum bilirubin, look at the albumin creatinine ratio. They are the little costlier one. What are the evidences and gaps in the knowledge of the dietary management in diabetic kidney disease? Protein intake, and everybody would ask you, especially the non-vegetarian people, what is known as recent meta-analysis demonstrate the association of LPD with preservation of GFR, especially in type 1 diabetes. What is unknown? The ideal amount of protein intake according to CKD stage and modification in diabetic kidney disease patient should be clarified. So this is one important job to us. Second job would be dietary source, from where they should take the protein, from vegetable source, animal source, what is unknown effect of different protein types on kidney function, mortality, the ideal proportion of each protein in respect to CKD. Carbohydrate amount we know, we all prescribe both high and low carbohydrate intake were associated with worse outcome in diabetic kidney disease, including reduced lifespan. What is unknown, what exact amount should be. Then looking at the dietary sources, whole grain carbohydrate, fiber, vegetable, recommended CKD. What is unknown, changes in carbohydrate and food selection. Then looking at the dash, associated with better blood pressure control, risk of diabetes and CKD. What is not known, impact of increased protein. Potassium is important. I'll talk in a moment exactly what they are. Phosphorus, diet, and modification advance of CKD. Mediterranean food is very popular. We know it. Restriction in the incidence of major CV event, type 2 diabetes with association of preservation of EGFR. What we do not know the effect in this diet on the outcome. And then, of course, dietary pattern, higher ratio, PUFA, fat, and this is the limitation of our knowledge. Coming to the malnutrition, and I said you in the beginning, the moment patient goes to stage 3 between 4 and is waiting for pre-dialysis or dialysis or RRT, his nutrition is a point of concern. He doesn't eat, and clinical studies have shown that the renal patient have inadequate dietary intake during early part. 40 to 70% patients with end-stage renal disease are malnourished. Protein energy malnutrition should be avoided. So we call PEW, protein energy wasting. And two types of malnutrition, type 1 and type 2, has been seen in diabetic kidney patient. This is the recommendation in acute kidney. This is a little busy slide. What is important for you to consider in stage 3 and 4? The calorie intake should be still kept between 25 to 35 kilocalorie per kg. Protein should come between close to 0.6 to 0.8. Usually restricted potassium, and we should know what are the potassium which food which contain very high potassium. Phosphorus is a concern, and most of the non-vegetarian diet and processed non-vegetarian food has a high phosphorus content. Aroma compound have a high phosphorus content, and they should be reduced to 10 to 12 milligram per gram per day. Calcium, we require them, so we prescribe them as a part of prescription of CKD patient. And fluid should be initially unlimited, but as patient proceeds for dialysis, it should be 1 to 2 liters. As patient goes for a specific program, accordingly, their physician, they tailor it. What is this protein energy wasting and why it occurs? It occurs because of the inflammation, which is coexisting, inadequate dialysis. If it is on the program, lots of interest in the food, anorexia, because uremia being very quick molecule diffuses very quickly from the gastric mucosa, produces gastric erosion, lot of GERD, and a lot of these patients have a bad smell. They don't feel like to eat. Inadequate nutrient intake. Hypercatabolism is important. Acidosis, which is there, and it gives you a very bad smell. It comes in the mouth and this breathing. Comorbid conditions like we talk about diabetes, cardiovascular disease, infection. What are the factors related to the dialysis now? These are the, we would not be considering, but later as patient keeps on dialysis, getting regular dialysis program, his appetite, some of patients, the appetite that improves. Even in peritoneal dialysis become better, but associated conditions might restrict it. This is the prevalence of the protein energy wasting. It is 12 to 18% of the patient, stage 3 and 4 CKD onward. And then 18 to 75 of patients are going to dialysis. They experience it the moment they get it. And that's why little more liberal protein intake is recommended during dialysis program. And a study conducted by the Cambridge, 53 patients, stage 4 and 5 dialysis CKD reported 12%. So what we should consider these patients, are they protein wasted? Because we Indian have a very poor quality of intake. Now I'm going to talk a little bit on the normal recommendation and the pattern. Protein, normally we have 56 gram per day, male. In patient dialysis, we try to maintain pre-dialysis, CKD 42 milligram per day, female 36 gram per day, and then it will calculate 0.6 gram per kg body weight. Sodium should be restricted 1300 to 1500 milligram per day. Potassium should be cut down to 2000 to 3000 milligram, 2 to 3 gram per day. Phosphorus is a concern. I said all aromatic food, lot of non-vegetarian stuff, they contain very high phosphorus, so should be restricted to 700 milligram per day. But there are no specific values determined. Cholesterol less than 2 milligram, less than 2.5 milligram saturated fat should be recommended. Early assessment is important, because if you don't do it, then these patients ultimately, so gradually, by the time you start doing the program, they start deteriorating and their demand becomes very difficult and they don't eat anything. So to prevent, diagnose and treat uremic malnutrition, because of malnutrition itself may lead to anorexia and vice versa. Anemia is one very important point. If you don't correct anemia, and now we have a prescription how to correct anemia in pre-dialysis stage, then it leads to lots of appetite, bad smell, and poor drive. Recovery is slow and often incomplete. So by early identification, use of optimal diet and dialysis will lead to an improvement in nutritional status. One of the reasons why we insist upon the patient doesn't eat anything, becomes very uremic and not likely to go for a program, we insist that please have few dialysis sessions so that your appetite becomes better and then you start eating better. Causes of protein energy wasting, loss of kidney function. I said before, combined comorbid condition, then dialysis associated catabolism, then metabolic acidosis, hypogonadism. And it is an important issue. And now there are people who take replacement therapy. And also the GH hormone resistance, inflammation, and infection, all they lead to. And the consequences are they lead to infection, they lead to poor cardiovascular outcome, and the frailty and depression. Protein, what we should recommend them to eat more, if they, because we want to give them protein at least close to 15 gram per day, first class protein to 20 gram. Eat more class 1 protein like egg white, fish and chicken, low fat skim milk, soya, skim milk products, soya bean, pulses and legumes, because they are the only source for the non-vegetarian people, and mixed cereals. What should they should eat less or avoid? Red meat, egg yolk, organ or meat, full fat milk products, and shellfish. They should be avoided. Stage 1 to 3, when patient is there, we can give them ad libitum 0.75 gram per kg per day. So 55 gram, half cup milk, 1 egg or 2 egg white, 3 ounce meat, 3 vegetable, 6 serving of grains could be good enough. But the moment patient goes to stage 4 and 5 and not on dialysis, then he should get 0.6 gram per kg, that is 41 to 48 gram, half cup milk, 1 egg, 2 egg white, 2 ounces of meat. So from 3 ounce becomes 2 ounce. From it 1 egg, it remains 1 egg, but 3 vegetables, it becomes 2 to 3, less at least 1 vegetable. 6 serving becomes 5 serving. So all is stage, as the moment patient goes into dialysis, then you could be liberal. You can go to 1.2 to 1.3 gram per kg body weight. Protein intake recommendation for stage 4 and 5, again not on dialysis, then they should be further reduced, and we should try to prevent the malnutrition in MDRD and improve the symptoms of uremia. These are the busy slide, but this is the patient who are already on dialysis program. I'll not waste time here. What are the recommendation nutrition intake for dialysis patient? Again, I talked to you. This is a 35 to 30 per kilocalorie of the body weight with the people who are less than 60, 30 to 35, more than 60. So the difference of little 5 milligram per kg body weight. Fat 30% of the total energy supply. Water as per residual diuresis plus 1500. Whatever he's passing the urine, you add 1 liter in the during the cold season, you make 1.5 during the hot season. 40 to 80 milligram potassium, and individualized calcium about close to less than 1 gram day. Phosphorus should be 8 to 17 milligram per kg. This is the again busy slide, but then measurement that should be performed routinely in all patients. Like pre-dialysis patient, you should stabilize the albumin, look at the post-dialysis brain, look at the standard body weight, look at the global assessment program, look at the NPNA. This is difficult to do, but one can do it. And then one can stabilize the serum potassium, skin fold thickness, mid-arm muscles thickness, and also look at the X-ray absorption metering, and look at the pre-dialysis stabilization of the creatinine, blood urea nitrogen, cholesterol, and index. I talked about the protein before. This is the different calories recommendation. Again, this is the busy slide, but then we are concerned with pre-dialysis. This is the stage 1 to 4. Calorie should be 35, protein should be 0.6, 0.75 per kg per day. Sodium should be 2 gram, calcium should be 1.2 gram, and then phosphorus, we must match the lab value, and unrestricted water should not be there, and urine output should measure. Is dialysis has effect on nutrition? Certainly, yes. Less amino acid, hemodialysis, then you increase the intake, and then CAPD 2 to 4 gram per bag, loss of glucose, 25 gram in dialysate, loss of protein, more in the CAPD. Inflammatory sign lead to further deterioration in the protein intake because of the cytokine release and low-grade inflammation. These are the nutrition prescription for CKD patient. I talked before. These are the renal food pyramids. And this pyramid means as the disease starts, then this is the way you should ask them to reduce the intake. Fat, sugar should take occasionally. Again, dairy product 1 serving, protein 2 to 3 serving, vegetable 3 to 5 serving, fruit should be 2 to 3 serving, and they should get grain, whole grain, rice, cereal, sweet 6 to 11 serving. So depending on the number of serving each, you can ask them to plan their food. There are few sides now. The sodium intake you should cut because they're important one. Additional of you can add the lemon, vinegar, spices. They should eat less fat, and then they should look at the label what they're consuming. These are the lower potassium in your diet, and that's important. You can leach, you can boil, you can throw the water 2 to 3 times, and leaching would take out not only potassium, also to some extent phosphorus. And therefore, if the patient doesn't know anything, you can ask them to boil and throw it. Potassium important, I said in the beginning. Low potassium food like apple, grapes, berries, pineapple, cabbage, green beans, cauliflower. These are the low potassium food. High potassium food which they should avoid: orange juice, banana, potato, mango, melon, avocado, tomato, and nuts. These are the low protein diet prescription, 0.6 to 8. We talked to before also, and would benefit in the improvement of glomerular hyperfiltration, increase the proteinuria, decrease the uric toxins. There are studies, I have published many paper in about in the previous some of the journals in the European journals. Oxidative stress, metabolic acidosis reduced, phosphorus, PTH is reduced, insulin resistance becomes better, blood pressure becomes better. So a lot of advantage you have when you prescribe low protein diet in these patients. And nutritional status derangement is essentially characterized by loss of muscle mass and visceral protein, and then accordingly we can make it. So these are the tips for thirst and fluid. Track your fluid, avoid chewing lots of ice, avoid refill restaurant, avoid supersized beverages, limit salty food, small glasses at meal and medicines, and lemon and or lime juice or the water. Hot weather, you should try to keep little more fluid. Keep your mouth wet. Rinse your mouth with chilled water so that food is. Lipids. 30% of the total calorie should be there. Minimize the intake of the triglyceride and cholesterol. 10% of calorie from saturated fatty acid. 8% from SFAC, and PUFA 12%. So to conclude my presentation, poor nutrition is common in CKD and pre-dialysis patient. Nutrition counseling should be part of approach to kidney and dialysis patient. Routine nutrition screening assessment should be done for CKD. Qualified renal dietitian must be included in the staff of every dialysis unit, difficult to do in our country. And personalized nutrition plan worked out for every patient. Thank you very much. I'm sorry I did it little faster because I am on the gate, the boarding gate.
Thank you, sir. It was a very nice presentation and complete presentation regarding the pre-dialysis nutritional considerations. Because you have to catch a flight, I think we should take questions related to sir's
Few
topic.
question I can take. Still, they have started boarding, but still they have 10 to 20 minutes. You can, if
Yes.
you are interested, you can ask 1 or 2 questions. I may be
Sir,
able to answer.
sir, if I would want to start off with a pertinent question, because there is so first of all, thank you for a wonderful presentation, which was very much practically orientated, and I did learn a lot.
Yeah, I did
it
little
resulted in my-
modification in the slide which I got it. Yeah,
so much, sir.
go ahead.
So I just wanted to understand, say, for example, if there is no fluid overload status, in that scenario, how do you restrict the water intake? This is the first
See,
question.
I'll get you the very practical. My teacher's example, Professor Johnny used to talk to you. Look at the neck vein, because these patients are not for the regular dialysis program. They are the pre-dialysis. Look at the neck vein, look at the feet, and look at the liver. Clinically, if the patient is dry, the fluid intake and patient doesn't have basal gravitation, the fluid intake should be 500, whatever is passing the urine, you add about a liter or so during the hot summer. If patient is dry, then you should liberalize the fluid up to till the standard post-grad teaching was you give an IV line, because some of the patients become oliguric anyway. So you give an IV line, watch as these 3-4 clinical parameters. Patient starts passing urine, making little more urine, you become very happy. But the moment you see the jugular vein is full, whether external, internal, doesn't matter. He says in nephrology, these two are not very restricted sign. But if these are full in the sitting position, then stop the fluid intake, cut it down to 50% in pre-dialysis patient. Oliguria is an important component. He shouldn't be oliguric at any cost. The moment patient becomes oliguric, this is the time to reduce the fluid intake. As long as patient is up to 1 liter, you can give according to the how much urine he passes, you add on. In hot summer, you can make it 1.2 liter.
Sir,
Thank you so much.
Tripathi sir, I have got a question, sir.
Yeah.
Sir, since this is a pre-dialytic patients, now what are the clinical signs and biochemical signs we should monitor that the patient would probably is worsening or progressing? And how do you advise the nutrition part in such patients if somebody is...
Exactly. I said in the beginning also, yes. Ideally, you should have gone for the urinary nitrogen estimation, which is a very advanced technology, and then everybody may not get it. But you can look at the serum protein, albumin ratio. You can look at the ferritin value. You can look at the serum iron. Albumin will give you indirectly, and serum protein, the patient's nutritional status regarding to the protein. The ferritin and the hemoglobin would level to tell about the iron and food content. Now coming to the carbohydrate, you assessment depends on the patient pattern, what is eating, because they tend to vomit those patients, those food which has a lot of aroma. If patient would take those patient which food which doesn't have, so the indirect way would be looking at these 3 specific parameters. But if you have a facility, you can look at the nitrogen, and you can add the nitrogen value, how much nitrogen urinary their excretion. If it is on the low side, it would be better to give them more protein. If they cannot tolerate, then you infuse IV albumin. That would take care of this protein energy wasting. But it is limited. I said it is quite limited. People have done hepcidin measurement. That is the one which blocks the iron absorption at the level of the cellular level. So one can try that also. But these are the 2 very costly affairs. Otherwise, these are the 3 clinical assessment. I said in the beginning, clinically also you can look at the anthropometry measure, look at the muscle mass, look at the skin fold thickness, look at the Bitot spot. All those standard old teaching might be able to help.
Do you put these patients on insulin, or prefer any specific oral drug in a pre-diabetic state?
In pre-diabetic, because the appetite is poor, insulin has an advantage. It improves appetite most some of these patients, and they feel better. So I would go for insulin. I love to give them insulin because of the improvement of their appetite. But I monitor their food intake. And it's always good to give short-acting insulin because that would increase their appetite rather than long-acting, because long-acting becomes unpredictable. So I would rather go for waiting if they can afford. Otherwise, short-acting sulfonylurea is good enough. We continue with the metformin if it is there on the prescription. But if EGFR is less than 25 to 30%, we don't prescribe. We hold on the, because it adds on to the acidosis, and that makes it little worse when these patients go to the ICU.
Sir, your thoughts on iron supplements, sir, because the calmness thing we see.
I said beginning, yes, rightly. I said serum ferritin as well as TIBC level you should measure, and we are routinely giving now IV. We have a now good brand of IV ferritin. RN is available, and maltose and sucrose and all those are much better than before. But we also give a good number erythropoietin to support with. It improves the iron absorption and makes a good blood level, hemoglobin level.
I think most of the issues we have got it answered from sir, and because he has to catch a flight, we should not make him delayed till his name is announced.
I think I'll ask one question, sir, if you allow me, please. Just one question regarding this renal specific nutritions with low protein content. You know, what is your comment on that? How
I am all for it. 0.6 grams. See, the limitation is our patient don't eat very much, and the protein usually, if I gave you the list on one side, I can send you the slide again. I gave you the list because there are some protein like vegetable protein which don't make them vomit, but other like coastal area patient who are taking fishes and they're taking other non-vegetarian stuff, they tend to vomit a lot. Therefore, I would restrict 0.6 to 0.8 gram per kg if they are not on dialysis program, pre-dialysis program. But still, if they feel vomit, I would go for a supplementation with vegetable protein, soya protein. They are little better tolerated. And if it's still not there, then I can go for parenteral replacement of the protein. They are very important. In foreign countries, they go. You have worked there, you know, they go for IV replacement by the parenteral. And there are very high cal diet, high lipid diets available, high protein IV nutrition supplementation is available. So they go for it, but it's a very costly proposition. In India, we can't afford it.
N-acetyl cysteine and you know, like the keto supplements that many of the
wonderful. See, that was see, keto analogs. They are the essential amino acids, and they compete in the synthesis of the urea and in the creatinine cycle, and thereby they reduce the turnover of the creatinine. So keto analogs, they are costly, but now they have become part and parcel of the prescription. I did not include because they are not part of the diet. So I didn't include them. Had it been prescription for the management, that certainly are one. But because my talk was limited to the diet, so I wanted to cut down and make my presentation within 20 minutes, 30 minutes.
So much.
And 30 minutes is over. 30 minutes.
Thank you.
Thank you, sir, for a wonderful talk. I think you must go for the departure gate, otherwise.
Thank you.
We don't want that you should miss the flight. Supratik will not leave until
Thank you.
So we wish you a safe journey, and thank you very much for the presentation. For the next talk, I request my co-chair, Dr. L. Srinivas Murthy, to introduce Professor Maheshwari, and topic is very interesting. As you know, the diabetes and altered immune function. Can nutrition help?
Thank you, sir. And it's my privilege and honor to introduce our governor, Dr. Anuj Maheshwari, who's kept all our council members on the toes, and literally every month is designed topics in such a way which are all practically useful and undertouched. It's like we say undernourished. So that is why we have a National Nutrition Symposium this month, and we are tackling with these issues which are very, very practical for us. And I'm sure all of you have heard Anuj sir in literally every other nook and corner conferences. Latest he was in Andhra Epicon, with the governor of Andhra and Telangana also. And he's been professor and head of Department of Medicine in BVD University, Lucknow. And Sir has been vice president of our national RSSDI. He's been the governor of American College of Physicians India Chapter. He's been a national academic coordinator and treasurer, Indian Society of Hypertension. And he's got more than 75 papers presented at international and national forum. And recently he had presented even in Japan, of course, virtually, unfortunately. And he's got 50 plus publications on diabetes, hypertension, and its complication in all indexed journals. And that talks about his academic excellence. And of course, he's received R.J. Wegman Oration in Indian Society of Hypertension in 2015. He's been awarded B.C. Bansal Oration in annual conference and V.G. Nadagoda lecture in RSSDI, P.R. Prasad Oration by RSSD Jharkhand. And of course, the most important, he's been invited for Kurokawa Oration in ACP Japan chapter in 2019 at Kyoto University, and Sanofi lectureship in diabetes at Epicon, last physical Epicon, which was there in Agra in 2020. He's been the recipient of 2016 Notable Achievement Award in Hypertension Prevention and Control at the population level by World Hypertension League. And also he's been a recipient of Marvelous Personality of the Year. I think that award describes his personality also and his achievements by Governor of UP. And I think that is the highest award we can, given by a government, that is by the governor. And Wellbeing Champion at 2018 by American College of Physicians. And I'm sure he is going to take the ACP India chapter at a greater level, I'm sure, because in the last 3 months, we have seen him literally, and he's taken as if he's been the governor from 3-4 years. The way he's acclimatized all of us is that that shows his interest and his commitment to the ACP, and we're all very fortunate to be associated with him. And I'm sure the topic, as Jayant Panda sir said, is again the background of pandemic. All of us, not all of us, the patients started talking about nutrition, and that is where the nutrition came into picture. But we know diabetes and immune alteration is the key role, and can we correct this basic defect with the nutrition is going to be the topic of the day. Over to you, sir.
And before Professor Maheshwari starts, I think I just want to add that he is a wonderful human being, a good friend, and as all of us know, he's been a mentor to many of us. So a privilege to have you on board, sir.
Thank
I completely echo.
Thank you for the kind words to all my friends, those who are here. So I'm sharing my slides, and first of all, I must congratulate Supratik Bhattacharya for organizing this wonderful evening on Sunday with nutrition, because this is actually very much a neglected topic in the society. Many of the times we talk about the nutrition, but we do not follow the nutrition. We do not really make them into the practice whenever we talk about the nutrition. So today I shall be talking in next 20 minutes, diabetes and altered immune function. Can nutrition help? And in last, very rightly said by Dr. Srinivas Murthy that in last 2 years, when we suffered with COVID, we started talking more about the immune system, more about the things what we should eat so that our immunity may be stronger and stronger. In fact, this immunity has dragged our attention in last 2-3 years only. As far as the population basis is concerned, we were very much looking over that, very much thinking about the immunity as a doctor, but it was not so much of the talk of the town. It was not had so much of the noise level. As you all know that diabetes statistics is growing globally, not only in India. It is 50% increase is expected in next 15 years as far as the diabetes patients are concerned. But more important is that it is growing very fast in our Southeast Asia region. It is, although it is not the fastest is in the Africa, followed by the Middle East and North Africa, but in Southeast Asia, which comes third in the world, where its growth is 74% increase expected in next 15 years. So diabetes is no doubt growing like anything. It's growing like its speed of the jet, and we must do something more than what we are doing for the treatment simply. So based on the epidemiological evidence, individuals with diabetes are more prone to acquiring infections. This very well known to all of us, and all those diabetic patients are more susceptible to certain complications when they are getting infections and coming across with multiple pathogens again and again. Important thing is to understand that if we keep our diabetes under control, probably we may not come into so many of infectious diseases. We may not suffer of those infectious diseases. Our immunity would be stronger enough to fight with those infections. It's very simple. What we really wish to understand, glucose is a very good culture media for any bacteria. For any microorganism, glucose is just a thing which can increase its number. It is the energy, it is a source of energy for us, it is a source of energy for human beings, for animals, for everything which is live on this earth. And for the same reason, whenever the glucose of the body is exceeding of its limit, it invites so many pathogens inside of the body. And when these pathogens are coming and attacking together from all corners, obviously body's immunity has got its own limitation. Apart from that, important mechanisms which are related to the specific infections like skin ulcers and lesions, and there are the things which happens in the body of a diabetic patient like poor wound healing, which do not allow the wound to heal, it do not allow the infection to heal, which keeps on it continuing for a longer time as it remains in the non-diabetic patient. Comorbid neuropathy, increased UTIs are also such things which invites more and more difficulties if a patient is having the diabetes. Despite the individual specific mechanism for increased infectious disease prevalence of individual with diabetes, the common pathogenic mechanisms are associated with the immune dysfunction. So all these things which are related to the more of inviting the bacteria, but at the same time, when more of the bacteria are invited by high level of the glucose, the immune system of the body also gets weakened to fight with those bacteria which are coming from the outside. As far as the immune functions are concerned, we could understand very well now that there are two different types of the immunity exists in our body. One is the innate immunity, another is the adaptive immunity. This innate is to the non-specific initial defense mechanism which is triggered upon pathogen recognition. But adaptive immunity refers to antigen-specific responses, which are designed to eliminate and memorize the specific non-self pathogen. So whenever we are coming across first time with anything, it is the innate immunity which had to fight with that organism. Once that organism has been introduced to our body and our body is familiar to that, then adaptive immunity starts working there. While humoral immunity does not seem to be significantly altered in individuals with diabetes, there is significant number of reports showing alteration in cell-mediated immunity like chemotaxis, phagocytosis, cytokine secretion, and it happens not only in type 2 diabetes but also in type 1 diabetes also, and I think more dreaded in the type 1 diabetes. So major immune cell functions alterations which actually works in the diabetes to attract more and more infections, which does not allow it to heal also, are the chemotaxis, phagocytosis, cytokine secretion. Apart from that, the altered functions of the immune system in individuals with diabetes are enumerated as reduced activity of the natural killer cells reported in type 2 diabetes, more of the pro-inflammatory macrophages in adipose tissues, which are more commonly seen in the obese patient or patient those who are having more insulin resistance, increase and decrease in neutrophils reported in type 1 diabetes, and of course the T cell subtypes show abnormal differentiation in type 2 diabetes. When we talk about the glycemic control and risk of infection, there are certain studies which has proven this association very strongly when they have been done in various parts of the world. The results and conclusion of one of those studies has shown that diabetic adults are at higher risk of infection-related mortality, and the excess risk may be mediated by the cardiovascular diseases. When we talk about the glycemic control and risk of infections among people with type 1 diabetes or type 2 diabetes in a large primary care cohort study, we can see the results were in the form of long-term infections. Risk was much higher with increasing HbA1c for most of the outcomes. Compared with patients without diabetes, those with diabetes and optimal control and poor control, they had elevated hospitalization risk for infection. Means those who were having not diabetes, they were having the least hospitalization, followed by those who were having the diabetes but with optimal control, and of course where highest number of the hospitalization was seen those who were having diabetes uncontrolled. In patient with type 1 diabetes and poor control, this risk was even greater. Comparisons within patients with diabetes confirm the risk of hospitalization with poor control after adjustment for duration and other confounders. So overall, the current analysis demonstrates a strong and likely causal relation between hyperglycemia and infection risk for both type 1 diabetes and type 2 diabetes. Substantial proportions of the serious infections can be attributed to poor control. Interventions to reduce infection risk largely have been ignored by the diabetes community and should be a high priority for future research. When we talk about the micronutrient deficiency, it is taken up into the very right perspective that it contributes to the immunodeficiency. Immune functions depends on metabolic pathways, which employs various nutrients as critical cofactors. Numerous enzymes require the presence of zinc, iron, vitamin B6, and other micronutrients. So in this way, if all these things are deficient in our body, this is commonly associated with impaired immune response, particularly maybe deficiency of the cell-mediated immunity, phagocyte function, cytokine production, poor secretory antibody response, poor antibody affinity, and of course, low complement system. Nutrient deficiency in healthy adults are often not so much taken care, often overlooked. As per the general clinical practice, only patients with a known risk factors are screened for deficiency. Often deficiencies like those of vitamin A, B12, D, iron, zinc are profound in non-hospitalized individuals. But nutrient deficiencies are also common in healthy adults. So it is not only the people, those who are sick, they are having nutritional deficiency. A big number of people, those who are looking like healthy, apparently healthy, they are also having the micronutrient deficiency. This is a very good slide, which I would like to drag your attention on this slide. We usually consume a number of medications in our day-to-day practice without thinking they can cause relevant micronutrient deficiency. For example, proton pump inhibitors can cause vitamin B12, vitamin C, iron, calcium, magnesium, zinc, beta-carotene deficiency in our body. If a person is taking the aspirin, most of the elderly people are given aspirin for the cardiovascular reason, they can cause the vitamin C and iron deficiency. Diuretics, if they are regular part of your treatment algorithm in the form of the loop diuretic, potassium sparing diuretics, and ACE inhibitors, calcium channel blockers, then the chances of getting the deficiency of the calcium, magnesium, thiamine, zinc, potassium, folate, zinc, potassium, iron, folate are high. Statins users are having the chance of getting the coenzyme Q10 deficiency with vitamin D deficiency, vitamin E, and beta-carotene deficiency. You know that metformin users may develop the vitamin B12 deficiency. In addition to that, the calcium and vitamin D deficiencies are very commonly seen. The people, those who are using the insulin sensitizer, may be metformin or thiazolidine. Glucocorticoids, either it is oral or it is inhaled. In both conditions, it may end up with the nutritional deficiencies in the form of the relevant micronutrient deficiency like calcium, vitamin D, sodium, potassium, chromium. They all can be seen while oral consumption of the steroid. But when inhaled consumption of the steroid, still we can have the calcium and vitamin D deficiency. Selective serotonin reuptake inhibitors may also develop all these deficiency with calcium and vitamin D. And when we talk about the estrogens and the progesterone, vitamin B6, vitamin B12, folate, calcium, magnesium, vitamin C, vitamin E, these is a list of those deficiencies which may be seen. But hardly ever we look for these deficiencies if our patient is consuming these medications for a long time. Nutrition in diabetes, when we talk about that, we all know that nutrition in diabetes is stood on 4 pillars. One is the nutrition, another is the exercise, medication, and monitoring. So diabetes management is based on these 4 pillars. But nutrition and exercise, these 2 are the most important, but very rarely they are given the due importance by patients especially. Whenever a patient starts coming to the doctor, he thinks that probably now everything will be done by the medication. Nutrition today takes center stage as it makes the immune system stronger. It is one of the microbiome which can help us in increasing the immune system, improving the immune system, as well as taking us healthy, taking our GI system healthy. And now a number of researchers are coming up with the microbiome. Even microbiome can also regulate the level of insulin resistance in a patient with or without diabetes. Of course, it controls the metabolism too. So nutrition in diabetes is a very important pillar, which we know as medical nutrition therapy. Mostly this medical nutrition therapy is not given its due importance. For many individuals with diabetes, the most challenging part of the treatment plan is that there is not a one-size-fits-all eat-page pattern for individuals with diabetes, and meal planning should be individualized. So of course, we need to tailor the nutrition in different patients in a different way. Therapeutic use of the nutrition for the purpose of disease management is one of the important part of the MNT, but at the same time, the prevention of diabetes in the patient, those who are having high insulin resistance, those who are having in the pre-diabetes, is also very much required because not so many drugs are allowed to use in that situation. So this is the medical nutrition therapy which can only help you in the primary prevention for the diabetes, as well as in the secondary prevention from the complications. Again, the medical nutrition therapy has its very important role. If you are using the medical nutrition therapy, probably less amount of the medication, less amount of the insulin shall be required, and you will be corrected or normoglycemic, or you will be treated well with less amount of the medication. So goals of the medical nutrition therapy is enumerated like emphasizing a variety of nutrient-dense foods in appropriate portion sizes in order to improve overall health. To address the individual nutrition needs, it is based on the personal and cultural preferences, health literacy, numeracy, access to healthful foods, willingness and ability to make behavioral changes, and barriers to change. When we talk about providing the practical tools, they are required for developing healthful eating patterns rather than focusing on individual macronutrients and micronutrients or single foods. To maintain the pleasure of eating, this is the biggest thing which is required whenever we are planning a diet for any patient, may it be diabetic or non-diabetic, having weight loss, requiring weight loss or not requiring weight loss. The pleasure is the thing which must be kept intact whenever we are planning a diet by providing the non-judgmental messages about food choices. Micronutrients and their role in immunity function. This is the part which we must know, and it's very much important for all practitioners especially. So vitamins which actually works for the epithelial barriers like vitamin A, vitamin C, vitamin E, and zinc. So when they work for the epithelial barriers, they do not allow any pathogens, any foreign pathogens to enter inside the cells. Cellular immunity, which is responsible for taking away the outsider invaders like vitamin A, vitamin B6, vitamin B12, vitamin C, vitamin D, vitamin E, folic acid, iron, zinc, copper, selenium. And antibody production is supported by vitamin A, vitamin B6, B12, vitamin D, vitamin E, folic acid, zinc, copper, and selenium. Now, this question arises, which is very much a specific question for the diabetes management, because whenever we are treating diabetes, we are trying to get number of ways to achieve the good control of the diabetes in least number and least amount of the medication. So is there any role of the diabetes specific formula? First of all, we should know what is diabetes specific formula. This diabetes specific formula has been designed if you include in your diet slow digested carbohydrate, which has got the low GI glycemic index, reduced postprandial glucose response. Then it should be added with MUFA, monounsaturated fatty acid, which replaces the saturated fats, supports lipid levels. Then prebiotics and dietary fibers, which promote the bowel health, improve lipid profile, and micronutrients support the metabolism, support immunity. So DSF means are oral nutritional supplement which are intended for use in people with diabetes. These are specifically designed to address not just the nutritional need, but to also complement overall glycemic outcomes when appropriately incorporated in the meal plan. Now question arises, regular versus slowly digested carbohydrate, how do they really work? You can see in this graph, the regular carbohydrate works like that. Whenever you are eating them, they will take the glycemic graph very sharply rising, and then it comes down to the baseline, and sometimes it comes down to the more below than the baseline. But when you are using the slowly digested carbohydrate, they are not taking your glycemic graph like this very sharply going rise, and you can see almost a straight line level of the glucose when you are using the slowly digested carbohydrates, which has modified your diet in a very specific DSF. Glycemia for establishing this thought whether this really works well or not, a study has been planned. In this particular study, one arm has been given glycemia targeted specialized nutrition. Another arm has been given the calorically matched glycemia targeted specialized nutrition. Another arm has been given the normal breakfast meal consisting of the oatmeal. So there were three types of the things which have been compared together. In fact, this study had its objective to evaluate the impact of the consuming one of two convenient and healthful breakfast options. Those were compared with the skipping breakfast on postprandial blood glucose, insulin and glucagon-like peptide GLP-1, total energy intake and appetite. So what we could see here, the one group, one arm in which a oatmeal breakfast has been given, which has been compared with the another group in which calorically matched glycemia targeted specialized nutrition, which we call it glycemia targeted specialized nutrition GTSN, has been given, and this has been compared with the third group which has really not controlled on these things. So what we could see that, and the third group was those who skipped their breakfast. Means they were having the high postprandial glucose, and many of like our patient, those who skipped their breakfast, they started doing that. So you can see that what was the results of their adjusted plasma GLP-1 curves over the time when they have been compared within three groups. Skipped breakfast was having this kind of the picture. So GLP-1 analog, which is an analog GLP-1 is the protein or hormone, this hormone which controls the glucose level, which helps in secreting more of the insulin, was going down and down, those who were skipping the breakfast. Those who use the glycemia targeted specialized nutrition, they found a very good rise in the GLP-1 level, and oatmeal remained in between. Here also you can see that glycemia targeted specialized nutrition having almost 4 to 5 times higher level of the GLP-1 hormone secretion as compared to those who have consumed the oatmeal, and those who skipped breakfast, they were just not got any rise. So DSF has showed better glucose management and improved lipid metabolism. As per the meta-analysis, DSFs were found to be superior in significantly reducing postprandial glucose peak, significantly reducing incremental glucose response, improving the variability of glucose level, reducing HbA1c from baseline, mean administered insulin dose, significant reduction in triglyceride level, and significant increase in mean HDL level. Indian evidence, a pilot study has been done evaluating the effects of diabetes-specific nutrition, supplement, and lifestyle intervention with CGM on glycemic control in overweight, obese Asian Indian adults with type 2 diabetes. What we could get the result, adjusted mean change in HbA1c in the two group. One group in which we have given the intervention food or glycemic adjusted food nutrition was having a good fall in HbA1c as compared to those who have not been given that kind of the intervention. Adjusted mean change in the HbA1c level, again you can see it was better in the intervention group as compared to the control. Fasting plasma glucose corrected much better as compared to the control. Adjusted mean change in the plasma glucose, what we could see here in for the covariates, baseline LDL, diabetic medications, baseline 1 and 2 and 3rd months were quite different. Again, changes in the carbohydrate percentage, protein percentage, and fat percentage. All this has been considered for the intervention purpose, and we could see that intervention group has fared much better as compared to the control group. Mean amplitude of the glycemic accretion was better with the intervention group, although this glycemic variability is again very challenging to address with the nutritional intervention. So conclusion is that a significant decrease in fasting plasma glucose and HbA1c was observed in the intervention group. There was also a great decrease in postprandial plasma glucose and lower mean amplitude of glycemic accretion in the intervention group. There was a greater decrease in the body weight in the intervention group. Intervention group participants also reported improvement in satiety after taking this intervention in nutrition, which was given the name of the DONS. So summarizing the benefit, we used this DSF, which constituted of the slow digested carbohydrate, MUFA, prebiotics or dietary fibers and micronutrients, where they have been combined together, and this has been given in the form for the nutrition for the study purpose. And what we could get the outcome of that, there is significant number of the reports showing alterations in cell-mediated immunity like chemotaxis, phagocytosis, cytokine secretion in both type 1 diabetes and type 2 diabetes. Based on the epidemiological evidence, individuals with diabetes are more prone to acquiring infections and are more susceptible to certain complications while infected with pathogen. There is a strong and likely causal association between hyperglycemia and infection risk for both type 1 diabetes and type 2 diabetes. There is also a role of micronutrient adequacy for appropriate functioning of immune system. Several commonly prescribed drugs over long term can cause deficiencies of certain immunity nutrients. Nutrition plays an important role in management of diabetes, which needs to be complete and balanced, which can support glycemic control and provide micronutrient support. So DSF has a role in supporting glycemic control, and they also provide micronutrients to support immunity. Thank you very much for your kind listening.
Thank you, sir. Just like the supplements, you put everything in the box, the micronutrients, the microbes, just what the DSF is available. Similarly, your talk consisted of everything in a concise manner. I'm sure this is a very, very vast topic which has been covered in just about 24 minutes. And thank you very much for that, sir. And Supratik will retain sir for question answer session until the end.
No, I am here. I'm
Yes,
here.
sir.
We will
Dr.
take the
Narsingh
question
Verma's
and
talk.
answer
We shall
after
have
the
a question
presentation
answer
of Dr.
session.
Narsingh Verma.
Yes.
Yeah, because
I'm here.
Governor
Welcome,
sir
Dr.
will stay with
Professor
us
Narsingh Verma.
for another half an hour. And
No.
it's a pleasure. Silent. It's a pleasure presenting you a session on panel discussion. Nutrition in critically ill patients. We know how important the ICU and the critical care has become during this COVID time, and most of the patient recover very well with the treatment given for the primary illness. But if you think of nutrition, that's the part always neglected, and immunonutrition itself is very important, so also the critical care nutrition. So Professor Verma will be presenting a very important aspect of the nutrition in critically ill patient. I request the RX team to share his CV. Professor Verma is a senior faculty in Lucknow now, and the King George University, Medical University, is very proud for his presence in the association. His MBBS, MD, FRCP, FSCP, FIACM, FICN, and Fellow of Diabetes India, involved in teaching and research in more than 35 years, and credited with 169 original publications in peer-reviewed journals, received 6 international and 26 national awards in the field of cardiovascular and metabolic research, and Secretary General in Indian Society of Hypertension and Indian Society of Chronomedicine. He is the president of Asia Pacific Society of Hypertension, and the conference preparation is going on of a grand event, and is the president Association of Physiologists of India, president UP Diabetes Association, the secretary of UP chapter of RSSDI, and president of International Association of Medical Nutrition. So who can be a better person to speak this important topic of nutrition in critically ill patient? With this, we present you Professor Narsingh Verma for the topic nutrition in critically ill patient. Professor Verma, please share your slides.
Thank you, Dr. Panda, for the introduction. And thank you, organizers, Supratik Bhattacharya, Dr. Panda, and Dr. Anuj Maheshwari, Governor ACP, for giving me this opportunity to talk about nutrition. Nutrition has no area for me because I feel that nutrition has been neglected in the curriculum.
Sir, your voice is not.
My voice is coming or not?
Now it's better, sir. Now it's better.
So nutrition is basically neglected in all medical curriculum, whether you talk about MBBS, MD, or any super specialty. And whenever the nutrition is taught, it is taught in that particular language which nobody understands. So that is the problem we are facing. And I will be sharing my slides. My slides are visible?
Yes, sir.
Okay.
Yes, sir.
So basically, I will be talking about the challenges in the nutrition in critically ill patients. The topic has been allotted to me, but overall, I said in the beginning that the nutrition is a neglected area. And whenever the nutrition is talked about, it is talked in a very, very different language nobody understands. And for general physicians and those who are involved in the medical, you can say, treatment of the ICU or any other space, you will find that hardly nutrition is discussed and nobody knows the value of nutrition. So I will be talking about next 20-25 minutes, the challenges in the critically ill patients. Critically ill patients have different type of challenges because they have various physio-metabolic changes, and these changes may increase the risk of malnutrition because the demand is more and they're getting less. And because of that, reduction in total calories and decrease in protein intake, that complicates the deteriorating clinical condition. And most of the time, the patient is not recovering because the recovery is slow, and the cause may be lying in the nutrition itself, because more nutrition is required, more calories are required, more protein is required at that time, and they're getting even less than the normal times. Especially increase in sepsis, rise in inflammatory biomarkers, and metabolic imbalance. They result in multiple organ failure, shock, and mortality. This can be reversed in the direction, and we can reduce mortality. We can decrease the chances of developing multiple organ failure, and by correcting the various inflammatory biomarkers and metabolic imbalance by the help of good nutrition. Up to 60% of ICU patients suffer GI dysfunction. And when GI dysfunction is there, you cannot give something orally, and that oral supplement sometimes may not be sufficient. And due to impaired GI motility, impaired digestion, and impaired absorption, such GI dysfunction often coupled with inadequate calorie intake, and that may lead to critically ill patient to develop an energy deficit and lose lean body mass. And that have been seen in most of the COVID patients at the times we have seen all over the country. And most of the COVID patients, when they were hospitalized due to a variety of reasons, I will not say only nutrition, but average weight reduction in the patient who recovered well was in the tune of 10 to 15 kg. I remember when I was admitted for 11 days, I lost around 10 kg weight. So this is a universal thing. Through assessment of critically ill patient, that will help in deciding the strategy, how can we provide the nutritional support and how we can increase the better outcome. So GI intolerance in ICU patient is basically forcing the discontinuation of the enteral nutrition, and which is sign of the disturbed GI function. And this intolerance to gastric feeding has been reported up to very high level, up to 60% in the patient of ICU. And this can lead to the changes in the body protein deficiency is there, energy metabolism is compromised, delayed gastric emptying is there, abnormal motility patterns are there, and impaired intestinal barrier integrity. And we know because in the intestine, there's a barrier, and that barrier does not allow toxins to go inside. And when the cells of the intestine are having leaks, then the toxins can become endotoxins, and they can go inside, and they can create a lot of multiple organ failure. Fear of complications of gastric reflux is also an important factor. So consequences of this GI intolerance is seen in the form of diarrhea. Frequency of an ICU varies between 2% to 95% patients develop the diarrhea. Constipation is again very common, and the opposite side patient can have around 50% of them can complain of the constipation. The malnutrition is very, very common. It increases the length of the hospital stay, and more hospital stays are required because the nutrition has not been done properly and the recovery is slow. And increasing the duration of hospital stay increases everything, and impaired gut function significantly compromises the delivery of internal nutrition and results in the malnutrition. And that increases everything, more hospital bill as always. So nutrition intensive care unit, the internal nutrition is the preferred method of providing nutritional support to critically ill patients because they cannot eat by mouth. It is preferred over the parenteral nutrition because of its simplicity. Parenteral nutrition has a complex type of behavior, and the cost is more, and the fewer infection complications are seen when it is given internal nutrition, because intravenous line maintenance of that, the parenteral nutrition will require more money and more complications related to infection. The ability to protect the intestinal mucosal barrier is more when it is given the internal nutrition, because that is going to the intestine in the raw form, and that will definitely help the mucosal barrier to remain intact. When it is given in parenteral form, then it directly reaches to the blood and the plasma pool, and hardly the intestine has any role. However, feeding intolerance usually occurs during the internal nutrition and leading to adjustment or discontinuation of internal nutrition most of the time. So this is one problem. And when nutrient intake does not meet the body's metabolic demand, it can lead to malnutrition, and then we are forced to go for parenteral nutrition. As Professor Tripathi was telling, the parenteral nutrition is also available in the specific forms, but it is very, very costly, and it do has some complication to it. Importance of the nutrition support in critically ill patient: it attenuates metabolic response to stress, because stress is more and we need more metabolically active substances, and it modulates immune response, which Dr. Panda was hinting that immune response is very, very important, because this is required for the complete recovery. It prevents a metabolic deterioration, and here the nutrition is very, very important. It prevents loss of lean body mass, which is required there. Fat mass, if it is reduced is good, but the lean body mass should not be reduced. And in the COVID era, we have seen the loss in lean body mass. The muscle has reduced up to that extent in some patients that it took around 10 months to recover up to full, and decreases length of hospital stay when the nutrition is good, and decreases morbidity rate, and also improves outcome of the patient, also decreasing the mortality, need not to say. The various international guidelines, and here again we are flooded with international guidelines, and again I'm very sorry to say Indian guidelines are missing, because we are not having much data available, and whenever we are treating lakhs of patients, but we are very shy in recovering data, so we cannot produce our Indian guidelines. This is again a sorry figure. But the energy requirements, all these guidelines say one thing, that commencement of internal nutrition should be very, very early, within 24 hours of the hospitalization. We cannot wait that the oral supplements which have been given are enough. No. So internal nutrition should be started within 24 hours of the hospitalization. All the guidelines ranging from 2016 to 2019, they again say that within 24 to 48 hours, it should be early. And then they have the various requirements about the energy and protein depending upon the weight of the patient, or BMI of the patient, or the adjusted body weight. According to adjusted body weight, they have recommended that what amount should be given to an obese person and what amount should be given the person who is not obese. So, and depending upon that, they decide that how much protein and how much calories are to be replaced. The recommendation from Indian practice guidelines for the nutrition in critically ill patients, that again say that should be started early, preferably within first 24 to 48 hours, and tube feeding should be considered if even 50 to 60% of nutrition targets are not met. So if they are not meeting even 50% of the target, then we can switch over for tube feeding. If the nutrition requirement is not met adequately with even after 7 days of ICU admission, then uses of parenteral nutrition may be considered. So Indian guidelines are little liberal. They give a chance of the tube feeding, and I will in the coming slides, I will elaborate what is the problem with tube feeding. But still, I know that most of the nursing homes, most of the hospitals, they are still using a lot of tube feeding. And we all, during our internship and during our training in the medical colleges, have seen a lot of RALS tube feeding. So it is imperative that nutritional assessment is done by a well-qualified and trained nutritionist. It is written everywhere. Professor Tripathi was talking about qualified trained nutritionist, and Dr. Anuj Maheshwari also talked about it. But very difficult to get a trained, well-qualified nutritionist these days. And nutrition screening is done by identifying patients at high nutritional risk. The risk assessment should be there, and according to that, the nutritional status of Indian malnourished patient can be assessed by subjective global assessment. This is one tool. An initial monitoring of nutrition intervention must be done on daily basis, and nutrition plans should be modified accordingly. Not that one visit is enough. No, daily, I will say, from one meal to another meal. The assessment will definitely help. And nutrition assessment is detailed evaluation of nutrition status of the patient, and that should be individualized. There cannot be a set formula. The nutritionist had to work upon the patient and then decide what should be given, at what amount should be given. You cannot have a fit formula like a diet chart. As I said this, and in my own clinical practice, I hate diet charts. Because even in the diabetic practice, I do not prefer diet chart. Every patient requires a different formula. So the estimating energy protein requirement are the main thing. And protein requirement, we know that normally we require, in the normal situation, we require only 1 gram per kg body weight protein, or even less than that, 0.8 will suffice. But here, in these patients, the protein requirement goes high from 1.2 to 2, because a lot of protein is being lost. So the protein requirement increases, and it should be 1.2 gram per kg body weight. The calories requirements again should be 25 to 30 kilocalorie per kg, and this is body weight per day. So for the energy, 11 to 14 kilocalorie per kg weight, actual body weight day for patient with BMI in the range of 30 to 50, and 22 to 25 kilocalorie per kg ideal body weight if the BMI is more than 50. So these all guidelines are from the European countries. That is why they are talking about very high BMI. But we have to learn something from these guidelines, and the very well energy and protein requirement had to be met. That is the basic thing. Then coming to micronutrients, when we have talked about the energy requirement, calorie requirement, the protein requirement, then coming to the micronutrients, they are also required. A little high amount of micronutrients are required in these patients in comparison to the normal patients, which are healthy patients, healthy subjects. The pre-existing micronutrient deficiency should be evaluated, because the disease is not on 1 day, 2 day, because hospitalization occurs at the last, and the person is having disease from last so many days. So the micronutrient deficiencies pre-existing, and patients on formula feeds may not require additional micronutrient because they are already having enough micronutrients, vitamins, and trace elements. If they are on complete and balanced formula feeds, but that is very, very rare in my country. Micronutrients can be supplemented in patients on blenderized feeds and those on parental nutrition. I will come and talk about what is this blenderized feeds meaning. What we are all were doing, our training days, that we were using rice tube feeding. And in the rice tube feeding, a lot of feeds were made by the attendants themselves. And that was not very healthy, but we were giving that to various patients, especially the patients who are comatose, or the patients who are in the hospital for a very long time, especially the neurological patients, have lot of rice tube feeding. Preferred route of nutrition, internal tube feeding versus parenteral. So if the internal nutrition is preferably recommended over parenteral one as early nutrition in critically ill patient, and why it is recommended, I will talk about. Supplementing the parenteral nutrition at the end of the first week after ICU admission is advisable when full internal support is not possible or fails to deliver calorie target up to 60%, as I have talked earlier. However, combination of internal nutrition and parenteral nutrition should not be routinely recommended except for a specific indication. So we cannot combine these two except for very, very few conditions. Indications for feeding and examples are given here. unconscious patients, head injury, ventilated patient, definitely the feeding is to be required. And swallowing disorder, we cannot have the chances. And post-CVA, multiple sclerosis, motor neuron disease, as I was talking about, the swallowing disorder, physiological anorexia, and liver disease, particularly with ascites, and the upper GI obstruction, esophageal stricture, and partial intestinal failure, the post-operative ileus, inflammatory bowel disease, and short bowel syndrome. The increased nutritional requirements are there, like cystic fibrosis, renal disease, and we have to after the parenteral nutrition or the internal nutrition. The psychological problems again is one indication. So nutritional management by nutritional status and phase of critical illness, that is, we have to go by this, what is the patient's nutritional status. So first thing, as I talked earlier, is that we have to find out what is the nutritional status of the patient. If it is well nourished or moderately malnourished, then acute early phase, we can consider the internal nutrition. Do not use parenteral one. Energy targets is meeting less than 70% estimated or measured requirements. Protein target, except protein dose provided by delivering energy targets. If it is in the acute late phase, then internal nutrition should be given, and considering the parenteral nutrition if the internal nutrition is not enough. Similarly, in recovery phase, internal nutrition is given. So the severely malnourished patient require a different formula, and they have to follow the management for well-nourished patient and watch closely for signs of refeeding syndromes, specifically hypophosphatemia. So we have to watch for that. If phosphate low, replace and keep energy targets 50% requirement for 2-3 days before gradually increasing it again. So by this, we can take our internal nutrition in the ICU. Nutrition monitoring is critically in patients very, very important. As I said, daily monitoring is required, and identification of patient at risk of feeding intolerance may assist in development of strategies to monitor and manage nutrition intolerance. Here, the recommendation for the monitoring nutrition tolerance and adequacy are as follows. The gastric residual volume should be measured by syringe aspiration and not by suction pump. And gastric residual volume of less than 300 ml can be refed if it is not blood stained. Holding entering nutrition for the gastric residual volume less than 500 ml in the absence of other signs of intolerance should be avoided. However, the gastric residual volume cutoff range of 300 to 500 ml can be considered. In case of high gastric residual volume, efforts should be made to continue feeding with reduced volumes, but it had to be continued. We cannot stop it altogether. Prokinetic agents such as metoclopramide and erythromycin can be recommended in patients with intolerance and risk of aspiration, because then the prokinetic action will definitely help. And nurses should be trained for monitoring tolerance, because the failure will occur at this particular level because nurses are not trained. Then everything, whatever is written in the casebook, will keep on writing, but nothing will be followed. This is the protocol for the ICU, the patient admission, and the checking if the patient is hemodynamically stable. And then if it is yes, the job becomes a little easy. And if not, wait for stabilization. Only after then something should be done. If it is already stabilized, then internal feeding be initiated. If yes, then the oral monitor patient's intake, and tube feeding if oral is not possible. Again, we have to monitor. Similarly, tolerance had to be checked. So these are the things which we have to keep in mind, and tolerance had to be checked in between so that we can monitor it properly in the ICU. High prevalence of feeding intolerance calls for a specialized formula, because in some patients you will find that the intolerance is very, very high. And 64% of critically ill patients may experience GI intolerance. Up to 60% of internally fed patients experience diarrhea. Diarrhea is more common. And on average, 20% of patients are switched to peptide-based feeds due to intolerance of standard feeds. And this, we have to go into parenteral nutrition, and that is the peptide-based. Now coming to the internal feeding, There can be two types. One is the blenderized food, which is made by the attendants or by the hospital staff, and the scientific food, which is pre-packed food made by the industry. So factors to be considered when prescribing internal nutrition is critically ill patients, limitation of microbial contamination of feeds. Because the feeds which are made outside, they may have the microbial contamination. Normal healthy individual may tolerate this, but the critically ill patient may not tolerate even very few bacteria. Meeting adequate nutritional feeds safely and ease of use and the convenience for nurses, because that is also required. It is not convenient, they are not going to follow. And cost effectiveness, because in India we have to see the cost effectiveness. Blenderized tube feeding formula. The blenderized tube feeding formula is typically prepared at kitchen by blending food or meals into a liquid feed. We all were doing this, and most of our patients were doing this 10, 15, 20 years back. And this may be completely prepared from the homemade food or a combination of food and standard formula. And this is used in many developing countries. It's still used in my country. Most of the hospitals are using it. Limitation of this feed is that there's high microbial contamination. You cannot control it. Inconsistency in amount and supply of nutrient. Every feed will have a different nutrient supply. You cannot change it. High osmolality and viscosity have more chances of developing diarrhea. Possibility of blockage of the feeding tube, which occurs very, very commonly in our setup. Acute and potential contraindications. Acute illness or immunosuppression, greater risk of infection from contaminated food, and fluid restrictions may be difficult to meet nutrient needs, and continuous feeding requires formula to be unrefrigerated for several hours, and that again increases a lot of contamination. Clinical evidence on blenderized feeds show that more than 90% or more of blenderized feeds are contaminated. Study of hospital prepared blenderized foods in Iran found that 99% were unacceptably contaminated and presented a substantial risk for patients who received them. Another study in the Philippines found that 75% to 96% of blenderized foods were contaminated. So contamination is a big problem. Bacterial contamination is very high, and most feeding had unsafe level of contamination, so we cannot rely on that, and that is further complicating the problems in ICU patients. Protein in blenderized diet is again variable for the patient receiving 1.5 liters of the feeding per day. This would mean a difference of 51 grams of protein per day. So that is unacceptable, and that can create a lot of problem. You can see here the protein content going down. Outcomes of microbially contaminated blenderized diet can produce a lot of diarrhea, GI colonization, pneumonia, infection, prolonged length of hospital stay, and increased mortality. So all these things are bound to occur in a blenderized diet. And scientific formula diet is a better alternative. Here the Indian guidelines for nutrition in critically ill patients recommend that preferably use of scientific formula feed over blenderized feeds to minimize feed contamination, and also getting scientific quantity and correctness of the food required for that particular patient. Here, the slide has a mistake that they have written blenderized in place of scientific. So kindly read it. I have not been able to convert it because of the paucity of time, but it is you can read it like that. The upper one is the blenderized and lower is the scientific formula. So all these things have already been discussed, that what is the advantage of scientific formula over the blenderized food. So selection of appropriate internal feed is very, very important. Standard polymeric formula feed should be recommended in critically ill patients, and inconsistency in the nutrient level can be avoided using the standard formula, and routine use of specifically formula feed should be avoided, because that will again create a lot of complexities in comparison to formula feeds. Blenderized feeds deliver lesser energy and protein values. This had to be kept in mind. So type of internal scientific formula, they are polymeric, disease specific, immune modulating, oligomeric, and the modular products. So on these varieties, they are available. The formula has been made on the basis of that. The polymeric formulas contain whole protein as the nitrogen source, and content can vary greatly in terms of calorie density, macronutrient distribution, amount and type of fiber added, and vitamin, mineral, and electrolyte composition. So subtypes can be standard, or there can be high protein, energy dense, and fiber enriched. In different variety of patient, we can use one particular subtype. Description is there. Standard one has nutrient distribution as a normal diet, while high protein has more than 15% of total energy by the protein, and the energy dense is having 2 kilocalorie per ml, and fiber enriched having more fiber, 5 to 15 grams fiber in there in 1 liter. So normal, this is indications are, according to those indications, the standard high protein, energy dense, and fiber enriched formulas are used. Because in the bowel function disorder, we have to go for fiber enriched, while the energy dense are required in the conditions where fluid restriction or electrolyte imbalances are there, and in catabolic state they require high protein. In normal GI function, we can go for the standard one. So that gives us plenty of options that choose which formula should be given. Oligomeric, here the proteins are hydrolyzed to peptides, peptide-based amino acids, elemental, are a combination of both, semi-elemental. Composition varies, one or more nutrients are hydrolyzed, so suitable for patients with extensive impairment of gastrointestinal function. Here we require this particular peptide base, because the proteins will not be assimilated if given in these particular conditions. That is why the peptide-based formula are required. The types of internal scientific formula, we can further see that disease-specific formula are also there, and the contents can vary greatly in terms of calorie density, micronutrients, macronutrients, and type of fiber, and that we can have a subtype of renal, where the less protein and low carbohydrate, and the renal failure patients are the ideal patients for that. Hepatic one have high BCCA, low amino acids, low electrolyte, and the hepatic encephalopathy are the indications. Pulmonary one have higher fat content, and the ARDS is the indication. And diabetic one, as Dr. Anuj was telling, having low carbohydrate load, and diabetic mellitus, the ideal condition where this formula feeding should be done. The types of internal scientific formula may have, depending upon immune modeling, and immune modeling intended to modulate immune function. And here we contain predominantly one nutrient, protein, carbohydrate, lipid, fiber, and the model products can have any one of them, and that are required where the immunity is modulation is required. So to meet the farm nutrition management goals, critically ill patient need specialized peptide-based formula, promote GI and the tolerance in the critically ill patients, and deliver specific nutrients that promote healing and recovery. So they will decrease hospital stay, and they will increase the better outcome of the patient if they are used. How do peptide-based formula work in critically ill patient? The dietary proteins, we know that there are large peptides, and free amino acids 20%, small peptides 80%. So they will be more easily assimilated, and they will reach where they are required, and the requirement of the body will be met in those specific conditions. Indications of peptide-based feeding are the parenteral to internal transition, and trophic feeding, and dual feeding with parenteral and internal nutrition, which is very rarely required, I said in the beginning. Composition of standard versus peptide-based formula, if we see the protein, and the protein, intact protein is their standard formula, while peptide-based have the peptide one. So basically, the GI functions are important here. On the basis of that, we have to choose. And the absorption of amino acid, more time required for complete intraluminal protein digestion, followed by absorption of the liberated free amino acids. But in peptide-based formula, more rapid absorption than from the equivalent free amino acid. So more rapidly amino acids are there, free amino acids are there, and the peptides are absorbed, and they will reach to the site where they are required, and recovery will be fast. High luminal nitrogen concentration and luminal nitrogen excretion in the intact protein. If we talk about nitrogen absorption and retention, and more rapid absorption of nitrogen and reducing luminary nitrogen losses, and this is very, very important in peptide formula. If we talk about GI integrity, weakens gut integrity, intact protein, but peptide 1 maintains gut integrity. That is why in those special situations, we prefer the peptide-based formula. If we talk about fat, the standard formula has low MCT, high LCT, and the peptide one have high MCT. So that is required here. Medium chain triglycerides are important. MCT means medium chain triglycerides, and LCT means low chain triglycerides. So we are talking here about triglycerides and absorption. If we talk about absorbed slowly, the standard one, low molecular weight and rapid intraluminal hydrolysis facilitates faster absorption of the peptide-based formula. Similarly, source of energy do not fulfill the energy providing a role allotted to them in standard formula, but the peptide-based formula have rapid oxidation, rendering many ketone bodies and supplying a quick source of energy. So that is the best thing, and that will definitely maintain the weight of patient as well. So highlighting everything that critically ill patient undergo many physiological changes and that result in impaired GI motility. This is very important, and digestion is not up to mark and absorption is not good. Such GI dysfunction often coupled with inadequate calorie intake, and that makes the Karela and Neem Chaha, and that creates a lead to development of an energy deficit and losing lean body mass. And lean body mass is one parameter. If it is going down, the outcome cannot be better. In such patients, the eternal nutrition should be started early, preferably within first 24 to 48 hours. All the guidelines, the Indian and the abroad guidelines saying the same thing. Tube feeding should be considered if even 50-60% of nutrition targets are not met adequately within 72 hours of oral nutrition support. And blenderized feeds may have limitation, which I talked about: microbial contamination, inconsistency in amount and supply of the nutrients, high osmolality and viscosity leading to a lot of GI disorders, and possibility of blockage of the feeding tube. Therefore, scientific formula feeds are preferred over the blenderized one. And to meet the nutrition management goals, critically ill patients need a specialized peptide-based formula. These formula promote GI tolerance and deliver specific nutrients that promote healing and recovery. But here, I will like to mention here again that the things which I have talked about are the ideal one, because we have to think about the patient pocket as well. And definitely, if we talk about the specific formula diets, they are little costly from the normal tube feeding, which we are doing, are the, if we talk about blenderized feeds. So according to our patient, we have to select which formula to be given, which formula diet to be given. So thank you very much for giving me this opportunity. I was a bit fast so that we can have some questions if possible. I'm not a specialist of this particular ICU management, but whatever experience I have in the last 40 years of my clinical practice, I have worked in the ICU setup so many years, but not here 20 years back. Thank you very much.
Thank you, sir. We could see that you are in a hurry to discharge the patient from the critically ill to the ward.
Yeah.
You have successfully done it by your management of nutrition in the ICU. So we really appreciate, sir, for your elaborate lecture and touching upon the various aspects of management in the ICU, which forms the backbone of the treatment in the critically ill patients. I think, unfortunately, most of us do not concentrate on this segment in the critically ill patients. So now, Supratik, let's start the panel discussion. I think we request all the participants to post their questions in the chat box. We'll be very happy and eager to answer your queries.
Yeah, actually,
shall we check
Sharma.
with the team if we have any questions? So,
Yeah.
Adik, do you have any questions on?
Yeah, please post it in the chat, Hardik. Meanwhile, I think Dr. Panda, sir, you can begin.
Yeah. Actually, Professor Verma told very exhaustive, and I regularly manage, because medicine has become emergency medicine nowadays. All routine patients, they don't come. Only very sick patients, they come. So during COVID time, we did a lot of critical care training and the ICU management, and also post-COVID it's continuing. So he has touched upon every aspect of nutrition very minutely. Only thing, it has to be understood and practiced in the real life scenario. Let us take some practical tips from him. Before that, we have any question, Hardik?
Yeah, we have, sir. It's already come up in the chat box.
Yeah, we have role of microbiota, how important in nutrition or not. Dr. B.K. Chaudhary has asked. I think it can be taken by any faculty, starting with Professor Maheshwari.
Okay, thank you, Dr. Panda. I have also seen this question, and of course, this is a very good question, but we must always remember we should move. There is always a way where we should get corrected. You need to come from the similar way where the problem has arisen. We must understand why this excess of diabetes prevalence has arisen in our setup or in our generation nowadays.
I think Dr. Anus.
No, I am here very much. There was some problem. I think my battery.
Yeah, that what we saw. That you were searching.
The laptop was going down, so that's why I made some emergency management immediately. But now it has been done. So what I was saying, whatever the way of developing the problem, we have to find the way coming back in the similar fashion. Why did we get this much of the explosion of diabetes in this generation? If we understand this, we will find how does the nutrition can help it. As the question has been asked, Dr. V.K. Chaudhary, that whether the nutrition can reverse the diabetes or not, I will simply say nutrition cannot reverse the diabetes simply by going on its own way, only with the nutrition. If you really want to do something for the diabetes correction, reversal, or remission, whatever, you have to face the same track with which it has been developed. Why did it develop? Because of lack of physical activity. That is the main problem of development of diabetes and insurgence of this diabetes in India. Food has not been major role. Earlier, we were using so much of the sugary food, so much of the glucose in our day-to-day life and our day-to-day practice. Whenever we were moving from friend's house to another friend, we were offered a glass of sugary juice. Why it was offered? Now it has taken a shape of the cup of coffee and tea. But why this sugary juice was offered? Because whatever the energy we have spent reaching there, that can be replenished. That can rehydrate us with the water, and they can replenish our energy, what we have consumed. Now, problem is that we have not consumed anything nowadays. We don't consume, but we replenish. Without making any consumption, we simply do the replenishment, simply do the refilling. So whenever we doing the over refilling, obviously it is going to cause some problem. So that's why the similar genes we are having, what the genes were there in our forefathers, but in last 30 years, you know that how did the diabetes has grown, how did the prevalence of the diabetes has risen, not only India, across the world, because of the increased luxuriousness, lack of the physical activity is not only in India, but across the world it is there. And the countries, those who are doing more physical activity, you can, if you could have had your attention in my first slide, you could see that Africa is growing like 143%. Followed by the Middle East, which is growing by 95%, and India and Southeast Asia 74% growth. So the African countries, those who are having a lot of physical activity, they were doing more of the physical activity. They have been sluggish now, and they are growing much faster. In the similar fashion, the Middle East was the place where the people were not having anything to eat except the fishes. And now they are having all kinds of the luxuries there, and that is the reason of such a continuous increase in that diabetes. So if we include the physical activity in our day-to-day life, if we add that physical activity and eat only that much food, what we can really spend in the calories, that can really take us non-diabetic for a longer time. Although I'm not sure, and I don't say that whether a person has been diabetic, he will be revert back. He will never be the revert back, and where there will be one out of 1,000 or the 10,000 might have been one by chance, probably might have been some wrong diagnosis and whatever. I can't say that any reversal can occur, but definitely we can prevent the explosion of the diabetes by making some changes in our day-to-day life. Of course, food is one part of that, but food is not the everything. Rest of the things has to be taken care.
Thank you, Professor Maheshwari, for rightly answering both the questions. And really, the theme of the RSSDI Defeat Diabetes campaign is the physical activity. Mostly in the center of reversal comes one concept, the physical activity. I would like to take the opinion of Professor Verma also. And there is another interesting question: the diet plan for MBBS students in college. So I think no one can do better than Professor Narsingh Verma, because he is so popular among students. He can give them a right diet chart.
Yes, sir. This question I wanted to take, and a very good question by Dr. V.K. Chaudhary. Medical students are those students who are getting very bad food. Not today. This is continuing since very beginning. And amazed, from last 40 years, nothing has changed. The diet plan, what they are consuming is very bad. And not only diet, even their dietary pattern and their dietary habits and their dietary hygiene. Everything is very, very poor. I have seen surgeons coming directly from OT and without washing, they can eat anything. And I've seen that messes are very, very bad shape where they are getting food. But nothing is being done for this in every medical college. Even in my KGMU, the diet is not good. And the messes are same messes, not having the ultra modern things. They are not talking about the, if I have started one particular study, let it complete. In that, what I have done, a group of nutritionists and dietitians I have asked, and they will go to every good restaurant, 5-star, and by the trick, they will carry their food chart and also to the messes of our medical colleges. And they will try to find out what our students are consuming. Very, very bad. I will like to quote only one study which is present in ResearchGate. I published very long back, 35 years back. In that, the hemoglobin content of the inmate of the VL hostel, inmate of the medical college girls hostel, was compared to the Bilaspuri laborers, and was found that hemoglobin of Bilaspuri women was better than the inmates of the girls hostel. Why? Because the girls hostel were a lot of food fats, and they were eating in one tiffin 4 girls and a lot of food fats, while the Bilaspuri ladies were eating only the jaggery and bread 2 times a day, but a good amount of jaggery and bread, and working daytime increases their erythropoietin level, and the hemoglobin was better than the inmates of the girls hostel, having no physical activity, consuming 3 diets in one tiffin. From male hostel, 1 tiffin used to come to the girls hostel, and 3 of them were feeding on the same diet. So the medical students, I think, my opinion, they are not because of busy schedule, they take it very lightly. As I said in the beginning, our MBBS curriculum still gives no importance to nutrition. During MBBS, only the biochemistry people teach us nutrition, and they teach us various difficult formula for carbohydrate, protein, and fat, nothing to be utilized in the their medical times. And then comes the SPM department, preventive social medicine, and they talk about balanced diet only for the examination purpose. and they don't have anything special about nutrition. So our MBBS doctors, MD doctors, physicians, DM doctors, everybody does not have any knowledge about nutrition. And if you talk about 100 doctors and talk about them diet, 100 will have 100 opinions. They are not on same page. I still see one of dietitian asked to me in the morning only, I was having a lecture. She asked me, sir, you have told that all foods can be taken in diabetes. But my doctor objects that you are my employee. You cannot say that the patient can take banana. You can't say that. So that is the problem with the medical college, medical students, and medical curriculum. It still requires more attention for nutrition, because nutrition is a very vast substance. You cannot.
Thank you, sir, for that befitting answer. I have a point to get clarification from Professor Maheshwari. Vitamin D3 has come as a very important factor in immune intervention and immune modification in diabetics as well as in critically sick patients. And we have got a lot of evidence in collagen vascular disorders, in COVID, and different scenarios that vitamin D3 deficiency has become a critical platform for deterioration, for infection, and correction of this proteins. So little, you have already touched upon a little more about vitamin D3 and immunonutrition in diabetes.
Yes, Dr. Panda, you are very correct. We have established that vitamin D is behind the upsurge of so many diseases. We have established with many diseases, but we never tried to understand why did this vitamin D deficiency occur? Why every Indian is deficient in vitamin D at this time? When about 10 years before, when this vitamin D concept was just growing, at that time, I checked my whole family's vitamin D. And you will be surprised to know that we all were vitamin D deficient, except my mother. Except my mother, all were deficient in the vitamin D. Thus, going on to the same pattern, when I started checking in many of my patients and found those patients of the more than 60 or 70 years, they were having very good vitamin D because of they were not had that much of the luxuriousness of the life. They never have been of the practice sitting in the air conditioned room, in the not doing the physical activity. And apart from that, you must have been remembering few of my slides in which I have shown you few of the medications which are being given nowadays regularly to the people, like statin, one of the important reason of the vitamin D deficiency. Now, whenever a person starts getting beyond 50 years, almost 60-70% of the people start taking the statins for one reason or another reason. Aspirin is also being used in a number of patients. Apart from that, many other medications are being misused. Even without prescription, people use PPI. People use many other medications for the different reasons. You know that. People use this contraceptive agent for the in their routine day-to-day practice, and all they have got some or other effect on our nutrition balance. They are reducing the micronutrients level in our body in one way or another way, which is not being replenished. We are not having any plan. If a person is getting a statin, he should be having a supplementation of the vitamin D. We never had, if a person is being given metformin, we should check the vitamin B12 after some time, and he should be given something to replenish the vitamin B12. We never had similar kind of the things like in the female, those who are consuming the contraceptive pill for the and they are not being given any additional nutritional support. Still, I do not find any women who comes to my clinic after the age of 45 years or 50 years, she is not taking any nutritional supplementation when we all all know after the 50 years of the age, males also requiring the supplementation. Females are requiring more of the nutritional supplementation because of their changing hormonal status. But for one reason or another reason, maybe poverty, maybe they don't want to take the medication, maybe we are not focusing on the attention, focusing on the women's health much. So we are not doing any supplementation of these kinds of the things. So our focus is actually not on the nutrition. Dr. Verma has very rightly said. And as far as when he was discussing about the medical students and medical days of the medical schools, I must tell you one additional thing. When a person enters into the medical school or medical days, he starts consuming many of the things which he requires to help in keeping himself awake for a longer time. Like gutka, like tobacco products, maybe in the form of the cigarette, maybe in the form of the liquor, and many other things he starts consuming, and he tries to keep himself awake for a longer time. I still remember many of my classmates, including me, many of the times were used to having a study throughout the night whenever the examination. And this is the reason which changes our biological clock. So biggest effect comes to us. Instead of we talk to the population, we discuss the population, your biological clock change, but we never see our what is happening to our biological clock. Still, for one reason or another reason, I am bound to stay awake for late night, longer hours. So these are the things which are keeping an adverse effects on multiple things, including the micronutrients status, including the other nutrition status, and the same thing is with the vitamin D. So next we say that everyone should consume the vitamin D. Of course, everyone should consume the vitamin D, but before consuming the vitamin D, we should do something else also.
Thank you. Thank you.
Panda sir, I have got a
I think we had a brilliant session. We are just
I
crossing
think we
time
are time out.
last
Supratik
words
will
of wisdom
check
from
us.
each one of you, please. So starting with Professor Panda, will have one final word of wisdom regarding this nutrition session. Each one of you, please.
Yeah, actually, it was a very successful national nutrition symposium. I myself gained a lot regarding pre-diabetic diabetic kidney disease and nutrition, and also the immunonutrition in critically ill as well as in diabetic. And as discussed, it's a neglected part of the medical curriculum and very essential. If we see every patient before leaving the chamber asks us, "Sir, kya khana hai? Kya nahi khana hai?" But the doctor takes it in a negative sense and tells eat whatever you, and a lot of myths and misconceptions related to nutrition. So I must congratulate the ACP team, especially the governor and Supratik, for taking up this important issue. And everybody should take it personally to get themselves educated on the nutrition and different parts. And this should be applied to the patient for the right outcome along with the medications, which will help us in our clinical practice to get success.
Thank you so much. Professor Srinivas Murthy, please.
Yeah, Supratik, I think it was an amazing session. I think it's a small step towards a big leap, I would say, to educate ourselves and to our colleagues through ACP. And I really appreciate and congratulate for that. I think the diet and exercise part is the least amount of importance given by the doctors and by the patients as well. Because everybody wants a second drug, third drug to control their sugars or BP, but not to manipulate their diet and exercise in their routine practice. None of the patients ask, and most of us, including me in our busy practice, do not give enough time for patients to educate on the diet and exercise part. And we should emphasize this importance, and also taking care of ourselves. I think most of us do not, as Anuj sir also was confessing literally, that for something or the other, he is awake late nights. Though he wants to sleep at 10 o'clock, I see his mails at 2 a.m., 3 a.m. in the morning many a times. So that is something I think all of us should first revamp and rethink about our own health, our own biological clock, to, as in Nursing Verma sir language, I think the chronology of doctors has to be set right first. And that is what we request our colleagues. I'm sure it will be an eye-opener for all our colleagues and friends with this nutritional symposium, that they should take care about themselves, and then, of course, our patients also. Thank you very much for the opportunity. I'm very, very happy that I'll be more eager to participate in more and more such symposia and educating myself and also educating our patients. Thank you again.
Thank you.
So much for your words of wisdom. Going to Professor Narsingh Verma, please.
Sir, you're muted.
Thank you, Supratik, and thank you, the ACP, for giving this opportunity to talk about a neglected topic like nutrition. And I think I have said everything. The only thing I will like to say, final word, that knowing everything about nutrition and knowing that nutrition is important is still, the supplementation is not the only answer. We have to think that what should be eaten and what should be taken in the raw form, like the vegetables and a lot of fruits. They can provide everything we need. We may not need the supplementation. Even for vitamin D, I will like to recommend one article. If you can find, you can read. And that article was very, very good. I will not say that article was correct. I will say it was good. And that is for the without vitamin D. It was that pseudo vitamin for pseudo disease.
Thank you so much, Professor Verma. Going to Professor Anuj Maheshwari, sir, please.
I think all the important points has already been covered, but I again would focus on one thing, that our day-to-day nutrition is not actually at the bar. Because most of the times we do not choose right things to take. Whenever, as I was saying, whenever I come across many of the people in my clinic and I ask him, are you consuming milk? So many of them says, no, we don't consume milk. Females, I hardly find any female who is consuming milk after the age of 40 or 45 years. And you know that that thing is very much required for the people, those who are, especially in a vegetarian country, where the people are not getting the non-vegetarian food for their protein requirement. Of course, the milk is the only thing which can provide them the good quality of the protein, good quality of the calcium, but it is not being used. Many people don't consume in northern part of the country even curd. In the southern part of the country, we see that a lot of curd is being used in many preparations. In our part of the country, when we say that curd is to be used, you should start using the curd, that more than 50-60% people say that curd is prohibited because it causes cold. So that is the biggest issue. When you start using the good thing for the nutrition, there are a lot of things are coming, lot of obstacles and lot of controversies are arising in the people, among the people. And we can remove them one by one. We can remove them step by step. We should continue organize these kinds of the nutritional forum on the multiple kind of the people, sometimes even for the public also. We are obviously using it for the doctors, we are using for the healthcare professionals, but we should also come out among the public on the ACP forum. And then probably in 2-3 years or 4 years, people may start understanding what is the importance of the nutrition in our day-to-day life.
Thank you so much, Professor Anuj Maheshwari. Thank you so much, Professor Narsingh Verma. Thank you so much, Professor Jayant Panda. And thank you so much, Professor Srinivas Murthy, for all your words of wisdom. I think we are carrying forward a very important message. And the whole idea is to inculcate this knowledge into our clinical practice, and more importantly, raise awareness regarding nutrition in various forums with your patients, with your family members, and use it in your day-to-day practice. So with this, with the permission of the chairs and also our governor, we'd like to conclude this session. Before that, we'd like to thank our educational partner, Abbott Healthcare, as well as the RX events for their cooperation. So thank you so much for such a successful event, and thank you for your participation, and wishes for a happy Diwali in advance.
Thank you. Thank you.
Very happy Diwali to all of you.
Happy Diwali in advance. Good night.
Thank you.
Good night. Bye-bye.